Hello, everyone. I am Dr. Alberto Salgado, and it's my pleasure to be here. And my topic today will be immediate implants in the aesthetic area. Well, first of all, I am going to give the lecture, but this lecture has to be shared with my partner, my specialist in aesthetics, Dr. Alfonso Diaz. And first of all, I would like to show you a little entertainment article we made like 8 years ago in a Spanish magazine. But the good thing of this, or the important thing of this, is that as you can see, we were talking about immediate implants, and several years ago we have a lot of interesting articles, lot of interesting publications in the topic of immediate implants in the aesthetic area. So what it means is that if we are talking about immediate implants, we have more and more literature that are supporting our protocols. And it was a time that when immediate implants have some kind of contradictions and controversial. But now I think we are getting more and more with safer protocols and faster protocols, and with important aesthetic outcomes. So I'm going to give you some kind of rules of which are the important aspects you have to deal with to achieve success with immediate implants. Rule number one: flapless surgery if possible, because this way we will have less possibilities of soft tissue and hard tissue restorations. Rule number two, and is extremely important, maybe the most important rule, is that palatal position is mandatory. Always, we have to leave a gap, a minimum gap to the buccal bony wall of 2 millimeters. If you have a slightly more, 3-4 millimeters is even better. Rule number three, and is obviously related with the previous rule number two: narrow implants mostly, no more than 4 millimeters of diameter in the aesthetic area to have this gap and to have better soft tissue around our implants. Rule number four is also extremely important. We have to place our implants in a proper depth, and the proper depth has to be related to the crown, not to the bone or to the leg or whatever. We need to know where is going to be our final crown before we perform an immediate implant. And then, if we know where is the limit of our crown, which is the shape of our crown, then we will decide to go 3 to 4 millimeters deeper from the zenith. Why? Because we have this biological width that has to be maintained, and an implant is 3 to 4 millimeters. So you have to put your implant in a proper position, 3 to 4 millimeters from the zenith. And obviously, not all implants can be under the bone. So we need implants with a proper connection, with a solid connection. Rule number five: you have to fill the gap with slow absorption material. There are some techniques actually that we are performing also. We are filling the gap with grafting the tuberosity, but this is the most the procedure with the most literature, with the most evidence, that it always with a slow resorption material like xenograft, we can maintain, we can preserve more bone than if we don't place anything. Rule number six: we need always temporary crowns, because if not, we are not going to be able to maintain our soft tissue. And the most important thing is that the best provisional crown that you can have over your implants is the natural tooth. If you can use your natural tooth and you can shape it, and you can use it even screw it or cement it, but preferably screw it to work with the provisional, is going to have a better result regarding to the soft tissue around our implants and our papilla. Rule number seven: obviously, if you perform in a proper contour of your restoration of your provisional crown of your implants, and you have a wonderful profile of emergence profile, but you don't send it to the lab in a proper way, then your final crown is not going to be good enough. So it's important to use any system, any method to make the adequate transference of the emergence profile and send it to the lab in a proper way. So this could be some pictures of how can we do it, but today with the digital scan that is extremely faster, more and more we can try to avoid this, and we can work in digital like we are doing now. And the good thing with if we have enough soft tissue, we can transform this soft tissue into a proper emergence profile, and we can make this profile that match in a perfect way with the other neighboring tooth. Rule number 8, soft tissue grafts are really important in made implants. There are new studies that are telling us that when we extract a tooth, we lose bundle bone, obviously, but we gain soft tissue. But if we perform an immediate implant and we try to place xenograft, we are not going to have this soft tissue increasement. We are going to have a reduction even in the soft tissue. So that's why we have to compense these volumetrical changes with hard and soft tissue grafting. And tunnel technique, I think, is the technique that we can apply in a better way in a flapless immediate implant in aesthetic area, as you can see in this picture. So let's talk a little more about clinical cases. This clinical case is class 2 in the classification of avian and terminal. So it means we cannot perform an animated implant because also we see that there is no papilla, there is no distal papilla, and also the phenid is even with recession. So it means that in this tooth that is already broken, it's a fracture, we have lost soft tissue in a perfect way. And also, if we know that there is a soft tissue recession, we know that there is a bone recession. But what I mean, the important thing here is that if we are talking about only one wall, we are talking about only the buccal wall, we still have a chance of doing to perform a immediate implant. Obviously, it's more difficult, it needs more delicate handling of the situation, and it needs obviously experience. But we can try to do these cases still immediately. So as you can see here in another picture, there's a deficiency in soft tissue and in hard tissue. So first of all, we perform the extraction. As you can see, the tooth is broken. Then we go for the root. We do the extraction of the root. You have the tooth is already extracted. Then we place our implant. We leave a gap, and then we make a tunneling technique. And you can say, are you performing partial thickness or total thickness? Studies, especially Sofia Laroque studies, allow us to tell that in these cases, this tunneling technique, we can perform a full thickness flap, full thickness tunneling technique, and this way we can use our tunnel to do soft tissue and also to place our membranes and do bone regeneration. So that's why we are performing, in the majority of cases, full thickness flap with our tunnel. And now we take our soft tissue. Normally we take from the palate and we epithelize, and then we place in the tunnel the technique that is tried with for many authors. And what we are doing here, we are using the same natural tooth of the patient, and we are placing this natural tooth as temporary crown, and we are also doing hanging sutures. And these hanging sutures, what are doing, are trying to condense this recession of the soft tissue. And 6 months later, we can see the healing of the soft tissue, and we have better volume, and also the distal papilla is increasing, and it's the time to go and to send it to their dentist for the final prosthesis. And this is the patient 4 years later. As we can see, there is still good volume in a horizontal way. And if we see now, our distal papilla is almost at the same level of the distal papilla of the natural tooth, and our phenids are at the same exactly position. So it means that our big aesthetic score is quite close in our implant to the tooth, and we have a result that is successful for the patient and also for us, obviously. We can see here. But what if we show you another case, and this case is even worse because we don't have papilla, we have this recession, the teeth is not at the same time, there's an infection, and the infection is in the palatal part and everything. But we are doing exactly the same. If there is a major defect and it's not it's a partial defect or of only one bone wall, we can remove the cyst, we can clean infection, we use hydroxyl peroxide in these cases for 1 minute, and then we place our implant, we leave the gut, and then we regenerate the bone, and then we perform our tunnel. We take the soft tissue graft from the palate, free gingival graft that we devitalize, and this way we can take the better soft tissue possible as described by Zucchelli. So we remove the epithelium, and then we apply our connective tissue graft around our tunnel with one single knot, and this is the healing 1 week later, almost no necrosis, even that we are using a temporary partial denture with some occlusal stops because of the biting of the patient. We cannot perform in a patient with this occlusion immediate loading, and as you can see here, there is a good volume. This is 3 months later. There is a total healing, perfect healing of our implant. This is the initial position, and this is the initial level of the soft tissue, and then this is the 3 months healing. So you can say, wow, it's a good improvement. We have several millimeters of volume in the soft tissue, but maybe this is not going to last. Maybe this is going to be only for a small period of time. But you can see this case also 4 years later. And as you can see, there is still a lot of volume in the soft tissue and also in the hard tissue. And this is the picture of the patient when he's partially smiling. And this is the picture of the patient when we go to a closer look and we compare one side to the other. As we can see, there is a perfect centric position, and also the papilla is even higher than the papilla in his natural tooth. It's in the same position. As you can see, the papilla is even higher, so it's a wonderful result. This is the initial situation, and our treatment. This is a 4 years situation. So rule number 10, and you have seen it in our previous cases. We can treat with immediate implants alveolus with buccal defects, also palatal, but only one wall, no more than 2 walls. I think 2 walls are risky, and also the literature tell us that. So let's go for a single small defect. This is a patient that is not our patient. We have several patients that are derivated from other dentists, and we do just a surgical part, and then our colleagues finish with the crown. So this is just for the surgical part. So we remove one crown that was already broken. The tooth was broken, and there's an infection in the root. So we split in half the root, and then we remove the root in two pieces, and then we perform this full thickness tunnel, and we use this full thickness tunnel to place a membrane inside as cream cone technique. And we use normally slow resolvable membranes, especially from Alpha Bio that we have that can stay in position 6 to 9 months. So we are performing here our full thickness tunneling technique, and we take our graft from the palate, we devitalize the graft, and we use one single suture to place in position, as you can see here. And then this is the situation, and we do a Maryland bridge with the same crown of the patient. And for 4 months later, we can see the volume, a better volume in the implant now than in the natural tooth, and also the teeth is higher in the implant and the natural tooth. You can see tooth and the implant, and this perfect position of the perfect regeneration. But not only we can do it in small buccal defects, it's even more difficult with palatal defects. But we are performing with the small palatal defects, we are performing our implants, even with immediate loading, especially with these neo-alpha-bio implants. And we are having good implant stability, so allow us to go slightly further with our cases. We can see a case that was also sent to our dental institute, and in this case was after the evaluation of his dentist, they decide not to maintain the tooth because the decay was below the level of the bone, and they decided to remove the tooth and go for an implant. So that's what we did. We performed extraction, and then we used this this handmade with our 3D printer surgical guide, and we place our neo-alpha-bio implants in the proper position. And as you can see here, it's extremely important. We know that there is a defect 3 to 4 millimeters in the palatal zone, so we don't want to put our implant completely at the level of the palatal bone, because if not, we cannot perform a bone regeneration. We need a gap also in the palatal side. So as you can see here, we have 2.5 millimeters of gap in the buccal side, but also there's 1.5 millimeters of gap in the palatal side, and this way we can have some kind of bone regeneration there. Now, as we know, there's a diastasis in the palatal bone. So we place this as lower resorbable membrane, and then after that we regenerate with xenograft mixed with autogenous bone, 50% in volume, and then we make small soft tissue graft, and we place it in the buccal part of the tunnel. This way we can keep the volume, maintain the volume. This is the initial immediate loading around our implant. This is the day 1 of the surgery, and 6 months later we have this aspect, and the implant is ready to send for the dentist, and we have perfect volume around the implant, and even the papillas are maintained at the same position, the distal papilla. But now we are going to major defects. We are going to show you 2 cases also flapless, and we are going to more difficult cases. Here we can see that there is a total absence of the papilla, mesial papilla, and also there's a fracture. So it's a case that is not easy, but this case can be managed with immediate implants and with a proper combination of aesthetic rehabilitation with veneers, and we can try to improve also with soft tissue graft. So this is the tooth that was broken. So let's go with extraction using our PFO surgery. This way we can perform an traumatic extraction. We can cut the tooth in 2 pieces as described by Araujo, and we remove the root, as you can see, and the tooth is completely extracted. And then we perform this tunneling technique, full thickness tunnel, and we take also soft tissue from the palate, we epithelize. This is after removing the epithelium, and then we place our membrane inside the alveolus, and then we place this soft tissue graft inside the tunnel. And as you can see here, we can perform also immediate loading. And what we are doing with the temporary crown, we are removing buccal and interproximal volume, our crown, to have more space, and because we want to have a creeping attachment, we want to do like a BOPT technique, and to make the soft tissue advance coronally. So this is the day 1 of the surgery, and as you can see here, this is after the final treatment. As you can see, we have maintained our papillas, and we have a nice result from starting from a difficult position, and this is I think it's 4 or 5 years result. Yeah, this is 5 years result. So we are happy with this result, even with in a difficult situation with our immediate implants. And now let's go for one major destruction in buccal bony wall, and to see also how is the result. This was sent us from Moscow, from Russia to Spain, and the reason of that is that the patient was a famous model and also singer in Russia, and she had an accident, a bicycle accident, and the tooth 2.1 was broken. So this was the picture that sent us. So we planned everything for doing an implant with extraction. Of course, flapless technique, because this lady has all her teeth with the veneers. So we started with the Benex system, do the automatical extraction. When we were doing the automatical extraction with the Benex system, we heard a noise, a crack, and I was really scared. I was thinking that maybe something was going wrong. And what we can see here is obviously because of the extraction, or because of the traumatism, sorry, there was a lack of buccal bone in the apex, in the apical part. So we have some buccal fenestration, but after the extraction, we have a completely loss of the buccal bony wall. So then we still go for, we don't have a buccal bony wall, but we still go for our immediate implant with our guide. We place our implant. Now we do this tunneling technique, total thickness, full thickness tunneling technique, just to place our slow resolvable membrane and to place a regeneration. You can see here the volume. You can see that there is no buccal wall, no at all. And we mix autogenous bone with xenograft, and we place this in the gap, trying to compensate with our membrane and with our graft this total absence of the buccal bony wall. Then we place PRF and we do a Maryland bridge. 6 months later, the patient returns to Spain again, and this is the situation. And as you can see, the papillas are in a perfect position, also the zenith, but this is the implant, there's the tooth, and also the implant in a surgical point of view. The bone is completely around the implant. There's no the sense and everything. So we can compare one to the other, and we can be happy because the result is looking good. But if we go and we take this occlusal look, we can see that there is a loss of volume in a horizontal way, and this is extremely important, especially in a person that is a model and a singer, because when she is going to smile and she is going to have a photo of her smile, there's going to be a shadow. So we need volume. So the second surgery is a small tunneling technique, as you can see, as you have seen in this lecture all the time. We take a very gingival graft, we epithelize out of the mouth of the patient, and we use this one single suture to place our connective tissue graft inside the alveolus. And as you can see here, inside the tunnel, you can see that 1 week later, there is a wonderful healing of our soft tissue graft. There is no necrosis. 6 months later, when the patient is returning from Moscow, you can see that there is a good level, better volume in the implant, in the tooth. But you can say to me, well, Alberto, this is a nice 6 months result, but what is going to happen with the time? Okay, this is a 6 years later result. You can see the crown placed by Napoli from Moscow, and you can see that the zenith is a proper position, in a proper position, even better than the natural tooth, and also the papillas are in a perfect situation. And if you see, the horizontal volume is still there. So as you can see, this is a protocol that from our point of view is predictable. Obviously, it's not easy. It takes experience and advanced surgeons, but we think that it's predictable if you perform in a correct manner. Rule number 11, as you can see, as we have seen in these cases, with multiple implants, the risk is always augmented, so we need to be even more careful. Rule number 12, treat the alveolus, all the alveolus. We have 4 gaps, 4 connective tissue grafts, and 4 gap regenerations. As you can see in this picture, every single alveolus in these 4 incisors that has to be removed, all these alveolus are with a graft, bone regeneration, also soft tissue graft, and also PRF. So rule number 13, multiple implants, always connective tissue graft. As you can see, we can perform a perfect volume for our final restorations, and we can create this papilla. Rule number 14 there is also similar that the one that I showed you before. If you have multiple implants, you have to transfer the profile of these multiple implants. And rule number 15, and we are closing to the most difficult cases, we can perform bone regeneration and connective tissue graft flapless and in one surgery. Is possible if you perform in a proper way your tunnel. You can see 2 teeth that were broken, and we have to do an extraction, and we have an extremely important loss of the buccal bony wall, especially in the tooth 1.3. So then we perform extractions. We use our neo-Fabio implants that can be used to have a perfect, good implant stability, even with not too much millimeters of bone support. We place these two implants. Then we do our tunnels, full thickness tunnel, and it's extremely easy in these cases because we don't have a buccal bony wall, especially in tooth 1.3. And then we take our slow soluble membrane, and what we are doing, we use a suture to join our membrane, to suture our membrane in our tunnel in the apical part. Is extremely important. This membrane goes to the apical part with the suture, and then between the suture, the outer part, no, between the membrane, in the outer part of the membrane and inside the tunnel, inside the soft tissue, we place our soft tissue graft. These are the 2 soft tissue grafts from Palatal. And as you can see here, we are placing our soft tissue graft inside the tunnel, and the membrane is in an inner part. So in the tooth 1.3, we are placing, first of all, our membrane with an apical suture, and then we extend our tunnel, and in the coronal part of our tunnel, we place our connective tissue graft with the same tunneling technique. And this is the rehabilitation, the final rehabilitation, also with aesthetic rehabilitation of our marvelous colleague, Dr. Alfonso Diaz. And as you can see, there is a proper maintenance of the tissue and a wonderful result for the patient and also for us. And last but not least, I'm going to show you what we can do when we have one of the worst things that we can have is a traumatism. So I want to share with you this surgical video to show what can we achieve with these protocols, immediate implants, and with these neo-Fabio implants. This is a traumatism from a flip. So we perform, first of all, root canal filling to try to avoid infections before the extractions, because we cannot perform the extractions and immediate implants right after the traumatism. They have to wait 4 to 6 months for the healing of this soft tissue and the bone, and then we can start with our implants. So that's why we decided to do these root canal fillings. We are cleaning all the alveolus. We have some kind of lesions, that is small lesions. We are doing carefully these extractions. We are using our protocols drilling in the palatal side of the alveolus. We use always with the second and the third bar, we use the biological protocol of drilling with the slow speed and no cooling. We can perform immediate loading over these two implants, and we are going to decide, because it's the desire of the patient, to individualize crown. They are not going to be split, they're going to be individual, just single crown over the implants in the temporary and also the final one. Newton centimeter square centimeter stability. We're testing our abutments for the immediate loading before adapting them, and also checking the position, perfect position for screwing. Now we place our healing abutments because we are doing the bone regeneration of our gap, and also the time technique for our soft tissue graft. Now we are placing our xenograft in the gap of our implant. Important that we fill it, and we have to put it. We have to compact this xenograft. We have to put it in a dense way. We don't want to have gaps between our gap between our grafting. So that's really important. Panels are made, we go to the palate, and we are going to perform this gingival graft. We are collecting this graft in a back position because we have more dense connective tissue, and we have to be sure that where is our palatal artery to avoid a risk of hemorrhage. So we are going slightly upper the palatal artery. It's extremely important, takes time, but we have to avoid cysts. If we leave some of this epithelium, we can have a cyst and we can have problems. I use my fingers because I want to avoid any pressure over the soft tissue. If I use another tool, I can have some kind of pressure points around my soft tissue. And now I cut in 2 pieces, 1 for each. I'm placing the soft tissue graft around these 2 teeth. I like to use this kind of suture just with one single suture message to distal, and we coat in the center to have a better profile around our implant. Now connective to epithelium in the meso part, and now we have our soft tissue graft placing inside our channel. These are the 2 implants placed with the soft tissue graft and then the regeneration. 6 months later, after removing the made individual temporary crowns, these are our over profiles. Now we are popping the emergence profile. You see the individual temporary crowns, these 2 implants. We take impression with these individualized impression copings. And this is the papilla maintenance that we have with these protocols. And this is 18 months later, the final result. Okay, thanks a lot. This is all that I wanted to share with you. And now I will be more than happy if you have any question, if I can help you with that. I will be pleased to answer the questions.